Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. You're invited to join us on air, asking your questions by calling in on the local rate phone numbers in the UK and the US, which can be found on ldnradio.org. Thank you for joining us. Today our guest is Physician's Assistant Paul Battle from Colorado. Paul is an experienced LDN prescriber and also has personal experience of LDN. This show is sponsored by Paul Battle, PAC. He is a well-respected physician's assistant who takes a physiological approach for your optimum health, using traditional and non-traditional treatments for autoimmune diseases and bone health, using hormone replacement therapy and low-dose Naltrexone. He has patients throughout Colorado and other states. Visit www.pabattle.com or call 720-773-9041. Thank you for joining us today, Paul.
Thank you. Really appreciate it.
Well, I know you've been prescribing LDN for many years. How long has it been now?
2008, I believe, is 2008.
Okay, I thought it was longer than that. In that time, how many different conditions do you think you've prescribed LDN for?
I would approximately 20 or so ones that I can recall right now. Mm-hmm. And they're all varying different conditions. The different classes, autoimmune disease. It does help with cancers that have had treatment already. I can't say it's a cure for cancer, but it's like a supplemental treatment, especially for people who've already had cancer therapy, stage 4 cancers. And then certainly the autoimmune diseases, which can include lupus, Crohn's disease, ulcerative colitis, complex regional pain syndrome. What I generally do is look at the disease mechanism, what the etiology of it. If it has some antibody-associated mechanism, autoimmune disease, then I consider LDN and the treatment. Many of these people really don't have any other option. They've tried multiple drugs. A lot of the drugs will have side effects, and they just are looking for another answer, and LDN can help with a lot of people that don't have any other options.
Mm-hmm. And from the patients that you've prescribed LDN for, what has been their success rate?
I would say the majority of the patients get some positive response. I would say probably close to 85% of people will get some positive response. Some are very dramatic responses. For example, I had a 13-year-old girl with Crohn's disease who, after just 3 months, she had already been on the biologics and was losing weight and having difficulty. She had no more symptoms. All her inflammatory markers were completely normal, and she's still doing well. And that was probably about a year and a half ago. Just saw her a couple months ago, and she's just doing remarkably well. Same with some of the complex regional pain syndrome. This is a terrible disease that plagues people, that causes severe pain due to some dysfunction or dysregulation of the immune system related to the nervous system. It's called the neuroglial cells. And some people I've had 80% relief from complex regional pain syndrome. I first started that in 2010 when this young woman who was attending college, she couldn't finish college. We had put a spinal cord stimulator in her, and in her neck to try and control the pain, but she still wasn't doing well. So that was my first proposal ever for CRPS, and Dr. Chopra wrote published an article a couple years later after I started this young lady on it, and it worked for her. She finished college, got a career, and after a year and a half, she went off the low-dose naltrexone without a problem. Mm-hmm. And since then, I've been treating multiple people with that disease with varying success. So it does vary, though. I never can guarantee somebody that I'm going to cure them or they're going to get 90% relief. We're just trying to improve the quality of their life.
And how long would you say it takes, on average, for somebody to notice that LDN is doing something for them?
Well, I've seen people respond in some positive fashion within 2 to 3 weeks. For example, my son, that's how I got interested in all this. Within 2 weeks with his Crohn's disease, he started having a positive response, getting better color, less pain, less symptoms. But I've also had people where it's taken 6 months. I had a woman who was a university professor with complex regional pain syndrome who just persisted. I said, just keep on. And she was in a wheelchair. Her symptoms were so bad she was disabled in a wheelchair. Then 6 months later, I got all these Facebook invitations to look at this video, and here she was returning to work, which was a glorious thing. And now she just texted me last week saying she did a 5K. That's going from a person in a wheelchair, totally disabled, to now running 5Ks. That's been about a year and a half now, but she stuck it out. And I ask people to be patient. Sometimes they do not think it's doing anything. For example, in her case, she said, Paul, I don't know if this is working. I'm just going to see how it goes without it. So one Friday night, she ran out of it, and that was the last time she ever skipped a dose. She said it was the worst weekend of her life. She described her spinal cord on fire. That's what she described. And I've had a number of other people saying, well, I'm not sure if it's working. They stop it, and then they discover it was really a mistake to stop it. So I tell people anywhere from a couple, 3 weeks to 6 months.
Mm-hmm. And from all the patients that you have prescribed LDN for, have any had negative side effects?
I think some people describe a kind of a tiredness or a little fatigue they may have. And sometimes it depends on when they take it. For example, most people take it at night, but I have a lot of patients with these syndromes that really create sleep deprivation anyway. And I don't want to have them risk their restorative sleep, so I have them take it in the daytime. And I think those people probably have a little bit more fatigue and tiredness than the people who take it at night. I've had some people just like any other medication, sometimes they'll have a little stomach distress from it, but that's pretty unusual, and I'm not even sure if it's the LDN. But the sleep deprivation, I really haven't had troubles with that too much because I titrate them up, fairly slowly over 3 week, sometimes 4 week time period.
And would you say there's any condition better than any other that you found LDN works best for?
I would say the inflammatory conditions of the joints work really well. Dr. Berkson's done great presentations on rheumatoid arthritis. I've had people who were on the biologics, that is the biologic agents that are what's called tissue necrosis factor inhibitors, who were doing okay on those, and they couldn't afford it anymore, so they went on LDN, and they actually got better results. One patient of mine now was mountain climbing. He wasn't able to move his shoulders for 3 years. Went on LDN, and now he's well enough that he's climbing with his kids. So I think the joint arthritis issues, the inflammatory bowel disease, especially Crohn's. I don't find ulcerative colitis as responsive as the Crohn's patients. So I kind of help distinguish that, and I kind of am careful to say how successful it is with ulcerative colitis patients, but it's certainly always a good idea to try it. The gastroenterologists are recognizing that ulcerative colitis and Crohn's may have some different mechanisms of action. The cancer patients, I've had several stage 4 cancer patients. They're outliving any of their compatriots with the same diagnosis. That's been good. And how much of that is the LDN? How much is it good health and good attitude? I don't know, but I just know the other people that were treated without LDN in their particular type of cancers are no longer with us. So I think it is a help because of the two mechanisms that LDN works. It inhibits cancer cell reproduction, and it also, according to the new research done last year by Angus down in Great Britain, where it actually helps change the gene action with apoptosis of the cancer cells. So I think it has a dual benefit there with cancer.
Mm-hmm. Okay. Well, we have a few questions here, and we will start with a question from Randy, who has Graves and Hashimoto's, and the question is, I've heard that LDN can lower thyroid hormone and send a person hypothyroid, but in the information it says it can quickly make a person hypothyroid. She said it again. Can it really have such an opposite effect? Sorry, she's saying hypothyroid, but I think she's meaning hypothyroid. Okay. So,
usually it's hyper.
Okay.
Because what happens is the Hashimoto's usually has a tendency, depending on what phase of the disease you're in. Graves usually are hyper, and that could possibly cause a problem. But what it is the naltrexone interacts with the antibody. So if a person is hypothyroid from Hashimoto's thyroiditis, I always tell them to reduce their thyroid supplements by half or 25%, because there's been a number of people who are hypothyroid. They're on their thyroid medication. They take the LDN, and the next day they're agitated. They're like on a caffeine high. They're hyperthyroid, because what happens is it has a tendency to neutralize the antibody action, whether it actually reduces the antibodies or how the antibodies respond to the cellular receptors with the antibodies to thyroid. We don't know, but I always warn people to cut their dose down before they take their naltrexone. Now, in the case of Graves' disease, I haven't heard of it causing hypothyroidism. I guess that would be possible if it's a lot of the inflammation is causing a hyperthyroid state, which you can get in Graves' disease, and you reduce that inflammation, you could possibly reduce the thyroid activity there, but I haven't had that personal experience with Graves' disease. Mostly I treat Hashimoto's thyroiditis, and that's the most common cause of hypothyroidism.
Mm-hmm. Thank you for answering that. I hope that answers the question for Randy there. We have quite a long question here, so bear with me. It's from Chantel. She says to thank you for being on the show and greetings. And she's a 54-year-old woman diagnosed with diffused systemic scleroderma 15 years ago. The only medication she's presently taking is IVIG and Plaquenil at 0.250. She lives in the UK and is currently in the process of finding an LDN doctor. She says she's noticed that you have experience in bioidentical hormones, and she would be very interested in your views on estrogen and testosterone, HRT. 4 months ago, she changed from oral HRT to testosterone gel to having bioidentical, isn't it? Bioidentical.
Bioidentical,
hormone, pellet implants estrogen at 50 milligrams and testosterone at 100 milligrams. And since she's had the pellets, she's never felt so awful in her life in terms of depression, mood, and rundown. And she seems to catch every bug going around, compared with the 4 months that she was on oral. Sorry.
Yeah, I didn't quite catch the initial diagnosis. Systemic, what was that, Linda?
Cerclodoma.
Systemic, what was the disease?
Cerclodoma.
Okay. Yeah, I'm not quite hearing. But if she's being treated with IVIG, that puts it in the same class of diseases that can be treated with LDN, because it's going after the same problem. That is autoimmune disease, immune dysregulation. I have a young girl who was also going to be treated with IVIG for a antibody-associated peripheral neuropathy. She had problems with antibodies to her nerve receptors, so she basically did not have a lot of function in her muscles, her GI tract, and they were going to give her IVIG, but it wasn't insurance approved here in the United States, at least with their insurance. So I offered them LDN, and that has proven to be very good for her. She's back in school half time. She was in bed or missed all of last year. So the answer to her question is, I think LDN would be a very reasonable possibility for her to approach her other disease. Do you want me to answer the question about the hormones now?
Hang on. The main question, when you get to the bottom there, because the testosterone and the estrogen implant is making her feel very depressed, very down, very moody. She feels awful. She felt quite good on the oral HRT. So she's saying to you, she wants to go on the LDN. Which should she take? Should she stick with the
oral or the pellets?
Yeah.
Is that what you said?
Which should she do?
Well, I usually use the oral just because it's easier to titrate the dose. When she got inserted pellets with the estrogen, it might have been too high of a dose. And once you put the pellet in the subcutaneous tissue, it's very difficult to adjust the dose. So she may be running very high. I usually like the estrogen to run around 60 to 100. That's what the literature shows to be protective against osteoporosis and coronary artery disease. But if you have too much, you can certainly have psychiatric side effects, just like women get what they are on the birth control pill. They can have depression. And as far as the testosterone pellets, the same thing. Once you insert those, you're kind of stuck with those for 3 or 4 months. So some people love the pellets because they don't have to deal with the daily pill and adjusting things. But in my experience, it's just easier to adjust. If she has trouble with the estrogen, you can just reduce the pill dosage. I work with compounding pharmacy, so I can make it whatever dose they want, 1 milligram, 2 milligrams. The oral therapy for estrogen has been shown to be more cardioprotective than say, for example, a pellet form or a cream form. So for that reason, the dosing can be easier adjusted when it's in a pill or a cream form.
Mm-hmm. Well, that's good. I think that was the route she was hoping to go down because she felt so ill and so down. So I think you've just confirmed it for her. So thank you for that. And thank you for sending your question, Chantal. Right. Here's a good one. Have you prescribed LDN for migraine headaches?
Yeah, I have several patients with migraines that I prescribe LDN, mostly because the current theory on migraine headaches is not our old theory of spasm of the arteries, because they've done arteriograms and found that the artery diameter doesn't really change a lot when people have migraines. So it's really more thought to be an inflammatory process, of the nerves, and therefore the LDN would be appropriate to try and adjust an inflammatory condition like that. So I do have several patients with migraines on LDN. I do other things too, but it seems like that's helped them. They were treated in traditional medications for years, probably 5 or 10 years, and I seem to be getting better results with the LDN. They stay with me, so obviously I'm doing something right for them.
And talking about headaches and migraines, have you ever known LDN to cause a migraine headache?
I haven't noticed it to cause a migraine, but I have had several patients say it does cause a headache, more of the dull headache, not so much the pounding vascular headache type of symptoms.
Okay. And we have another question. It says, have you seen LDN improve acne breakouts?
I have not seen that. I just haven't noticed that. I use other things for acne, so I haven't observed that.
Okay, thank you. And what is your opinion of using ketamine infusions in conjunction with LDN?
I think they can be. It can be done. I have patients who have an LDN that have had ketamine. If you just had one last week, the ketamine works in a different way. It's a dissociative anesthetic, and it works by blocking the NMDA receptors, N-methyl diacetate receptors. That's the receptor that transmits the pain to the brain. And so what it does is it blocks that. And so that really doesn't have any interaction with the LDN, because the LDN works on, opiate receptors, endorphin receptors. So we don't have any clash there. I think they can be used synergistically.
And what conditions would you use the combination of the two for?
That would be complex regional pain syndrome.
Okay.
When I used to operate on people putting in spinal cord stimulators, I would routinely, first I would give IV magnesium prior to surgery, and that has been shown in several studies that it can reduce pain 50%. That magnesium also naturally blocks the NMDA receptor, which the ketamine does, so that works with ketamine. And then I would give an infusion during surgery, and then after I would give an infusion for overnight to block the NMDA receptor so that the surgery would not precipitate an exacerbation of the complex regional pain syndrome, or what's known as RSD, or reflex sympathetic dystrophy. That's the only diagnosis that I've ever used it for, and I don't know of any other diagnosis that you would use ketamine for. Ketamine is a tricky drug. Adults can have kind of a miserable experience with it. They can have nightmares, and just side effects from them could be hypertension, tachycardia, hallucinations, things like that. So with adults, you do have to be careful with it. There's low-dose ketamine infusions, and there's high-dose ketamine infusions. Dr. Kirkpatrick at the RSD Research Center in Tampa, Florida, does a high dose. And I've been there and I watched him do his technique there. So that's the only diagnosis I can think of to use that combination.
Well, thank you very much. We'll just go to a quick break and we'll be back in just a moment. To listen to individual radio shows and interviews, go to www.mixcloud.com/LDNRT. I'll repeat that. It's www.mixcloud.com/LDNRT. This show is sponsored by Paul Battle, PAC. He is a well-respected physician's assistant who takes a physiological approach for your optimal health, using traditional and non-traditional treatments for autoimmune diseases and bone health, using hormone replacement therapy and low-dose naltrexone. He has patients throughout Colorado and other states. Visit www.pabattle.com or call 720-773-9041. Now we have a question here, Paul, which you can sympathise with. Amy has a 7-year-old daughter who's got Crohn's disease, who was diagnosed 4 months ago. She says, are other children taking LDN with success? What can I expect to see as in an improvement besides better sleep? Will it assist with pain and improve quality of life? And by that she means more energy and able to go through a normal school day. Will LDN take her pain away?
Yeah, you're right. That is dear to my heart because that's how I got started with my son. And for her to know, my son was diagnosed with severe Crohn's disease at age 10. I think it started at age 9. He had to have a good part of his small bowel resected at that time. 3 years later, he had another severe exacerbation going into hypovolemic shock. And so that is the time where I started researching, kind of taking it on by myself. And that's when I read Jill Smith's article in 2007 about LDN and Crohn's. And she's an excellent, well-respected gastroenterologist who did excellent studies on LDN and Crohn's, showing a remission. So if she wants to know if it works, within 8 weeks, 69% of the people in her first study showed that they went into remission. 89% of them showed that they had significant reduction in the Crohn's index scores. And what are those? The index scores are more symptomatic scores on, number of stools per day, cramping, bloody diarrhea, fevers, things like that. Those 89% of them had significant reduction in scores. So she can expect a very good possibility that she would have less pain because the inflammation is causing spasm, which is causing the pain. So if it reduces the inflammation, those symptoms will improve. They also will reduce the diarrhea if she's having diarrhea. You can get Crohn's any section of your GI tract from the esophagus to the anus. My son now, he's been on LDN for, 8 years now. He is a weightlifter. He's a bodybuilder. He's doing really well. He has a strict diet. So the one thing I would tell people is you don't depend on LDN alone. It's a multi-system, multiple approaches to solving the Crohn's problem. And if you do these other techniques such as dietary control and supplements, probiotics, things like that, you can expect to get good control of it. Like I said, I had a 14-year-old that really pretty much doesn't have symptoms anymore. Inflammatory markers are gone, so you can expect chemical markers for inflammation to be reduced when she's on the LDN. And yes, they've had children on it. I, certainly had my own son on it. Dr. McCandless treated many thousands of people with autism with LDN, and so it's proven to be very safe with children.
Thank you. That was an ideal question for you, wasn't it? Robin has asked a question. She's got multiple sclerosis. She's been taking LDN since 2005. And in that time, she's had no new lesions and no active ones. She's had MRIs. She says that she's no better, but she's no worse. MS, has been stable in all that time. She uses a cane away for balance away from home and uses a scooter in large stores. Now, what she would like to know is, does she need to continue taking LDN for the rest of her life, or is there a period of where she can stop?
It's a good question. I would, because she's been stable now, for almost 12 years, I would be very hesitant to stop it. There's not many people with MS that are stable for 12 years. You can have 5 or 6 years where you have this up and down cycle, but that's a long time to be stable. She has no new lesions, and the cost and the risk of LDN is so low, I don't know why she would want to consider stopping it. The other thing is the benefits of LDN with your immune system in general. It upregulates many of the things that help protect you from infections. It upregulates the natural killer cells. And with the new research in cancer and the old research in cancer with Dr. Zagon, it may help. I can't say for sure because there's no studies on preventing cancer, but certainly we've seen the action clinically on how it benefits people with cancers. I would really recommend that she stay on it, for the rest of her life. Like I've said before, there's people who thought, oh, there's no benefit here, I stop it, and they pay the price. And MS is not something you want to have an exacerbation. It could be quite devastating for some people.
Exactly. Yes, I certainly wouldn't want to come off the LDN.
Yeah.
We have an interesting question from Kat, and she says that she takes baking soda in water for reflux before she goes to bed, but she also takes her LDN before bed. And will the baking soda stop the LDN from being absorbed?
It might. I wouldn't really recommend that because of the baking soda itself could inhibit the absorption of LDN. It'd be best if she could take the LDN maybe an hour after that. By then, the baking soda should be out of her stomach and into her small intestine. So I really didn't. That's why we don't recommend compounding pharmacies to put calcium and other minerals in with the pills because it can disturb the absorption, of LDN. If she wants to do that, if she really needs the baking soda, then she might consider doing LDN in a topical form with the oil or a cream or something like that if she really has that much trouble. If she has that much trouble with reflux, she might have eosinophilic esophagitis, which LDN can be helpful for since it's also an immune-based problem, and that seems to be a more common diagnosis. So in the end, I wouldn't recommend her take it at the same time.
Just on a personal note, I used to have to take an antacid every night for acid reflux, which was really bad. It used to burn the back of my throat and absolutely awful. But having changed my diet and not eating gluten or dairy, the acid reflux has gone and I no longer have to take that medication. So I'm quite pleased about that.
Yeah, no, that's excellent. That was the way to do it. Glutamine also is another nice thing to do. It's just an amino acid, and that helps with reflux. It also, that's what most of the intestinal cells are dependent on for energy, and also helps with restoring the intestinal cells. So that's another thing she could try. But you're right, Linda. That's the best thing to do is just get away from those triggers. From the gluten and dairy, the two most common triggers for many of the diseases we're talking about.
Yes.
We're not used to those kind of proteins.
Yeah, but it certainly worked for me. We have a question here from Heidi, and she says she's got resistant depression. I've been on every type of antidepressant and been in counselling on and off for years and nothing works. I currently attend CBT. I am suffering from crippling anxiety, depression and insomnia. I've read that LDN can help. I'm very desperate for help. I wish to try it. Will it work?
That's a good question. Some of the psychiatrists at our meetings are saying it can help. I mean, it certainly increases the endorphins or at least the endorphin function. So that in itself can help depression. I don't know if it will help the anxiety. The cognitive behavior therapy she's doing is is helpful, but the newer research is showing that many people who have depression, it is an inflammatory condition. For example, people who have had a heart attack, the highest risk for reinfarction, that is another heart attack occurring, is depression. And it's not an accident, because inflammation from depression and inflammation in the presence of coronary artery disease can cause the plaque to be released from the wall of the artery, causing a coronary thrombosis. So I think it would be worthwhile. There are studies in, I think, Sweden and Japan showing that people who didn't do well on the medications did well responding to high doses of fish oil. And fish oil is also an anti-inflammatory, and I'm talking large dosages, for example, 5 to 10 grams per day of fish oil, because DHA, which is in the fish oil, makes a good part of the brain weight, about 20% of the brain weight. So in the studies at Purdue University with children anyway, shows that most of the kids with these kind of psychiatric diseases, 85% had low DHA. So fish oil is another anti-inflammatory, another option for people with depression. And the other thing that's important, since I do a lot of hormone work, is to make sure that the thyroid is optimized. I don't mean in the range or normal. I mean optimized at a good level, healthy level, not just in the range like 95% of the population. And that has been shown in psychiatric journals to be just as good as antidepressants for depression therapy.
I know many people who are using LDN for depression and anxiety, and have found that it really does help.
Mm-hmm.
You've certainly got nothing to lose by trying it, have you?
Right. It's a great economical thing with really minimal, if any, side effects.
Exactly. We have a question here from Robert, who's got CFS-ME. And he said, I was originally taking LDN at 4.5 milligrams daily. Now I'm taking it every other day based on an article which I have read recently. Which is recommended, taking it every day or every other day?
Well, we have all traditionally been prescribing it, every day because the blockade is 4 hours, and the immunological benefits that have been described by Dr. Zagan and Dr. Bahari himself show that the immunological benefits last for about 20 hours. For that reason, I usually do a daily dose. Now, for this person, if it's benefiting him every other day, his receptors may be more sensitive, and he does not need the 4.5. What he might try is to reduce the tablet in half and take, 2.25 milligrams a day versus every other day. But the pharmacokinetics, that is how the drug works and how long it lasts, it would be generally recommended to be on a daily basis. Now, you got to understand how LDN works. It is opiate receptor blocker, and if somebody has more sensitive receptors, they may need a lower dose or not as frequent to make their immune system actually most beneficial. That's true, we find, with cancer. We don't like to go too high on the dose. Anything above 4.5 I don't think is a good idea, because then you're blocking the benefits of the opiate growth factor that Dr. Zagan has described in the past. So he just may find a level that's good for him, and that's perfectly fine. But the pharmacokinetics usually indicate it should be a daily dose.
Mm-hmm. Thank you. We'll just have one more quick break, and we'll be back in just a moment. The LDN Research Trust has an LDN Vimeo channel. I have interviewed over 550 LDN prescribers, researchers, pharmacists and patients from around the world for many conditions. You can find the link on the LDN Research Trust website. If you'd like to be interviewed sharing your experience, please email me, linda@ldnrt.org. I look forward to hearing from you. This show is sponsored by Paul Battle, PAC. He is a well-respected physician's assistant who takes a physiological approach for your optimal health, using traditional and non-traditional treatments for autoimmune diseases and bone health, using hormone replacement therapy and low-dose Naltrexone. He has patients throughout Colorado and other states. Visit www.pabattle.com or call 720-773-9041. Welcome back. I wonder if you could tell the people listening, Paul, the benefits of attending the LDN conferences, either in person or the live stream.
Well, personally, I think I've been to now 4 or 5 of them, and the benefits certainly I get as a practitioner, but you can also apply as a patient or interested individual, is that you hear people from all over the world and the different applications that they're using it for. When I look at myself, I'm only one practitioner in my own experience, and I don't, certainly haven't treated everything. So it gives me a great advantage to listening to other speakers from anywhere around and what they're using it for, some of which I, really never thought of. The psychiatrists are talking about how it may help depression, it may help, sexual function, for example. I certainly never thought of that. So I think the biggest advantage is you're seeing, some of the top people around the world who've been using this for a while and all the different indications, so that if you have a disease that has not been a common one that we tote about LDN, like multiple sclerosis and Crohn's, but it's one of these more rare diseases, you then can say, hey, this might be an option for me, and then try to find an LDN prescriber to try it. It's such a low-risk treatment. It certainly would be worthwhile for a lot of different diseases. I think you've counted over 200 autoimmune diseases now I think we had experience with. So that's a lot of diseases to cover, and it's great to hear from other people around what their experience is.
And this year we're getting case studies and some pre-recorded presentations, because there was so much information there that we wanted to present to everybody. It would have taken like 2 weeks to sit there and watch. So you're limited to what you can do in 3 days, but there is going to be a lot of extra material there. But the Q&A sessions I find amazing, because not only do people in the room get to submit questions, but the people who are listening online as well. And there are some amazing questions that come up, and it's really interesting to see all these people that have been prescribing LDN for so long. Some of the questions are very complex, and answering them can be tricky. We had feedback last year from one doctor who said she thought the Q&A sessions were amazing and she had all her questions answered. She had some questions answered that she would have asked herself if she'd have thought of them. And the whole thing, the whole thing was believable, she said, because some of the questions that were asked, I think there were only a few, where nobody on the panel knew the answer, and they just shook their heads and said, no, I don't know that one. So for her, that meant every time somebody answered a question, they didn't answer it to give an answer. They answered it because it was a fact. So for her, that made the whole thing believable. So that was good. But I always find at the conferences, the atmosphere is electric. You've got all these people that are so for LDN, it's just amazing, isn't it? The actual feeling in the room.
Well, it is. It's a great camaraderie because this is really still not a well-known treatment, and it doesn't have salespeople, doesn't have commercials on TV. So it's really been pretty much up to people like you, Linda, who's been one of the leaders in promoting LDN around the world, and that's been my mission since it saved my son's life, is to speak at international conferences sponsored by you and sponsored by other organizations. I'm going to be speaking at the Medical Management Conference in Florida in April about LDN, and that's a whole different group of practitioners that will be hearing about LDN from myself. And it's just it's a nice progressive movement that's helping thousands of people around the world in a very economic way. And I just wish there was a way we can spread it a little bit more, but commercials are expensive, so it's dependent on all of us to be together. And that's where I feel a real kind of like a brotherhood and sisterhood about the LDN movement. It's we don't have a lot of help other than us volunteers or in your organizations.
And this is where the good thing is in sharing case studies and people getting together to discuss different ways of treating different conditions with LDN. It's a good way of everybody learning. We do have another question has just come in, and it's for rheumatoid arthritis. The question is, how long should I take LDN to treat my rheumatoid arthritis?
Well, I'm not sure if he's asking how long should he take it before he notices a difference, or how long should he take it to treat it. I would stick with kind of my time period that I said. He should probably have at least 3 or 4 months before he would expect any dramatic results. Just give it that much time. If he does have a good result in the end, if he can get 70 or 80% improvement, then he should just stay on it the rest of his life. Rheumatoid arthritis is not one that goes away. I would want to make sure, though, that it is rheumatoid arthritis. I had a patient in my clinic who was told by the rheumatologist, she had rheumatoid arthritis. And so for 3 years, she's been thinking she had rheumatoid arthritis, and I checked her for Lyme disease through Armin Labs, the German lab that we have come to our conferences, and she was positive for Lyme arthritis. So the question is always make sure you have the right diagnosis also. But if he gets a good relief, Dr. Bert Bergson in New Mexico has a great presentation on his patients with rheumatoid arthritis, showing the serological markers improving dramatically on LDN. And many of the people were able to get rid of most of their rheumatoid medications, of which a lot of them, have side effects.
Yes, and we've had a lady, Mary, who's been listening to the show, and she's talking about complex regional pain syndrome, and her daughter is 15 years old. She says, is it safe to take LDN at the same time as gabapentin? Her daughter is currently on 2,700 milligrams a day, and she'd love to get her daughter off the gabapentin, but it's the only thing that takes the edge off the pain. Is it necessary to go gluten-free to find relief? She said, I know she should, and I'm gluten-free myself, but her daughter is not ready to accept that's what she needs to do. Are there any studies out there on the long-term effects of using LDN in adolescents? I've been searching for weeks and finding studies difficult. What is the most normal dose for CRPS? She's 5'11" and weighs 140 pounds. Thank you for your help.
Well, that's interesting she brings that up, because I had that exact patient in my office about an hour ago. She's a CRPS patient on gabapentin, or was on gabapentin, and she's been trying to get off of gabapentin. I believe the gabapentin may have been helping her a little bit, because gabapentin can work with the LDN, because gabapentin helps attenuate the nerve transmission. It's a class of drugs like the anti-seizure drugs. So she can certainly use them together. And is there any studies? There isn't any long-term studies on kids. We just know that, like Dr. McCandless had kids on the LDN for years, and there's never been any problem long-term. My son's been on it 8 years without any problems. We have the OB/GYN doctors in Ireland who use the larger dose naltrexone, 50 milligrams, for infertility during pregnancy, and they've not had any problems. So I really can't think of any other safer drug. And I've been a PA for 35 years in a lot of different medicines that I prescribed over the years. I can't think of a safer drug than naltrexone at 3 milligrams, 4.5. For her at that size, I think the 4.5 milligrams would be the appropriate dose, but I would titrate it up. In regards to the gluten-free, I think when you have any kind of immune dysregulation, gluten-free is a good idea. The glutein proteins are not ones that we have been designed to digest. Dr. Tom O'Brien, who comes to our conferences, he's one of the experts on gluten, said to me last year that even a person without gluten intolerance that's been diagnosed or celiac disease still has inflammatory changes in their intestinal tract when they do biopsies 30 minutes later. So my recommendations would be, yes, to have her do gluten-free. I know my son with his Crohn's, it took a while, but when he finally realized, hey, this is his body, this is his future, now he's gluten-free, dairy-free, all that. So I would highly recommend that she go on gluten-free diet.
I appreciate what she's saying, though, having a 15-year-old daughter who wants to socialize and go out and be part of the crowd, and then you can't go out for a pizza because you can't eat it.
Yeah.
It's difficult, isn't it?
You have to do a gluten-free crust. A lot of pizza bars and Italian places have gluten-free pasta, gluten-free crust. I just had that last night, as a matter of fact. So it's workable now. It's much easier now for gluten-free meals and diet, and she can always bring her own food. That's what my son's done for years, is just pack your own food and have salads, things like that.
Well, it's not very easy in England to find anywhere that is gluten-free. You'll find that when you come over. When I went to a supermarket, we had to travel, and we were hungry, and I just wanted to grab something. I went in the supermarket and I said to the lady, because I couldn't find it, "Do you have a gluten-free section?" So she said, "Yes, but it's not very popular. We're going to stop it, and we've only got what's left on the shelf." And there were like 6 things, and it was like, seriously, it's not catching on, and you're going to get rid of the small section you do have. I thought that was quite amazing.
They need more education there, because the Northern Europeans, as I understand, have a little higher incidence than other population. Northern Europe, that's where they find it's 1% of the population. So I'm surprised at that. That's unfortunate.
And when you go, we took our grandson to the cinema last week, and we were looking at menus outside to see what there was that was gluten-free. Many places don't have menus, and we were looking at TGI Fridays, and went inside, and they actually have a gluten-free menu, and it was like, wow, a whole menu of gluten-free. You can choose. It isn't, this is it, take it or leave it. There was actually a choice. That was very good. I had a gluten-free burger and a gluten-free bun, and it was very, very tasty. It was very good.
Great.
I was quite pleased with that. I was going to say to you, Paul, and anybody else out there who's listening, if there are any conferences coming up where you're a speaker or you're attending a conference and LDN is going to be one of the topics, let us know. We actually have on our website now an events calendar for
Excellent.
talks and lectures. So yes, it would be nice to pull it all together so people can use that as a resource, and if they're available to go and listen or do it online, it would be a good idea. So you'll have to give me the details, Paul, and we'll put that on the event calendar.
Oh yeah, anything we can do to spread the word. You know, I love doing it, and if we can help, a couple hundred people, and mostly what I really like doing is teaching the practitioners, because if I figure each practitioner has 1,000, 2,000 patients in his practice, you've helped that many thousands of people at least be exposed to the LDN by teaching the practitioners. That I think is a big impact on it.
And word of mouth has taken hold, hasn't it? People are telling friends, and social media. I must admit, I didn't want to join Facebook, I don't know how many years ago now, reluctantly, thinking that's just another thing I don't have time for. But I think we have about 18,300 and something members now on there. And I'll take this opportunity to thank all the wonderful admin people that we have who answer all the questions and help and steer people and give them advice on how to find an LDN prescribing doctor. Without them, the Facebook wouldn't continue. But the number of people that pass through, who come, who go, who take the information, go to their doctors and get LDN prescribed, it's a wonderful tool.
Yeah, we just have to educate more people, more practitioners. Just not to let people may not be open to things that they're not trained in, and certainly the lack of a lot of clinical trials does make the practitioners a little hesitant to prescribe it. But if you educate yourself, I've read a lot. I've read all Dr. Zagon's papers, and convinced that it's definitely a good thing for my patients. I'm certainly not hesitant to do that, but you do have to get educated, and that's what we're doing.
Well, I'd like to thank you very much, Paul, for being with us today. We've just about run out of time, and you've been amazing. So thank you, and I look forward to meeting you in September, but I might meet you when you come over later in the year. Yeah,
this summer. That'd be great. Okay, Linda, I appreciate it. Really great time. I love helping out. Anytime.
Thank you very much.
Thank you.
Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.